Right, well, thank you very much for asking me. It is the second one I've done of these. I'm being reminded of my age here, I think, more than anything else. So my title, I've been asked to talk to you about genetics, when and who to test, and also to cover some of the new things that are happening in the genetics of polycystic kidney disease. So in 2016, when I did a talk on genetics last time, this is what we knew about the genetics of PKD, of autosomal dominant PKD. We knew that there were two genes, the commonest of which was the PKD1 gene, which is on the left. This is a very, very big gene, very difficult to sequence, producing a very, very big protein. And then second, and accounts for about just under 80% of what we knew at the time of autosomal dominant polycystic kidney disease. And then the second gene was PKD2, much smaller gene, a much smaller protein, and accounted for much less of the kidney disease, around 15%. But we knew at that time that these two genes were not accounting for all the individuals and the families that we had with polycystic kidney disease. And at that, and also now for quite a few years, what we have been able to do for individuals is identify the underlying genetic cause of the condition in their family. So just to cover some of the questions earlier. So there is, for the vast majority of families, there's just one gene fault running in the family from one generation to another in one gene. So that may be PKD1, PKD2, or some of the other genes. And that's what you pass on. And the fault in the gene that you pass on to your children, if you do, is identical to the one that you have yourself. There are some, and we have a few in our clinic, rather unlucky families where they have PKD1 coming down from one side and PKD2 coming down from the other side of the family. So we do have a tiny number of people who have faults in both genes, but for the vast majority, it's one gene running in a family. It's always the same fault going from one generation to another. And the easiest way to diagnose PKD, and the quickest, is by doing a renal ultrasound scan. It's cheap, and you get an answer in 5 minutes. So one of the reasons that we need to think about, why ask the question is, well, why, if it's a very easy condition to diagnose, would you do genetic testing in the first place? And there are an increasing number of reasons why we would think about doing genetic testing in order to identify in that family exactly what gene and what gene change is causing the disease. The first is to make the diagnosis. So the diagnosis isn't always straightforward. There may be no family history to guide us, to tell us that this is an autosomal dominant condition. It may be presenting in a very atypical way, and we've already had a question about the size of the kidneys. And so if you've got somebody with normal sized kidneys with cysts, what is causing that? And also, we sometimes get children with presenting with a lot of cysts. And is that the much rarer autosomal recessive polycystic kidney disease, which affects infants and children, or is this an early presentation of autosomal dominant polycystic kidney disease? And genetic testing will start to answer some of those diagnostic questions. The other reason, next reason that we might want to think about using genetic testing as a tool is to give us some idea about prognosis. So this is, how is that individual with that gene change in that gene, what does that tell us about the nature of their disease and how it might progress as they get older? Because we are realizing that how an individual done is influenced by the gene itself, which gene it is, and also the nature of the change within that gene, and I'll talk a little bit about that. And also, as Rosa's mentioned, it also identifies that group of patients that might get the maximum benefit out of the treatments that we have available to us at the moment. Third reason for thinking about genetic testing is it starts to enable us to offer options to families that have not otherwise been available. And one of those options is thinking about prenatal diagnosis, or perhaps more importantly, pre-implantation genetic diagnosis, as a way of starting to think about ways of not passing this condition on. And I'll talk a little bit about that as well. And then also increasingly important is the role of genetic testing in live-related kidney donor transplantation. Because what you don't want to do is take a kidney from a relative who themselves has polycystic kidney disease but may be too young to know it, and give it to somebody, because there is obviously risks to both if that happens. And then what are the things that we're still debating about? What are the things we're still asking ourselves? Should we be testing in these situations? And I think there are two main things that are the hot topics in who and when we do genetic testing at the moment. And the first is we're asking ourselves, well, why don't we just test everybody? Why are we still kind of saying, well, we do it in that situation, we do it in that situation, but, we know what's going on in this family, so there's no need. And I think we are starting to test more and more and more people so that we do understand the underlying genetic cause of their condition. The barriers in the past have been the cost of the testing, but the cost is coming down. The barriers at the moment are there just are not enough clinical scientists in the genetics labs across the country to do the volume of the work. And as we know, as Albert and I know, frustratingly, testing is taking a very, very long time at the moment because it's complex, very difficult to do, and we just do not have the workforce big enough to deal with it. But hopefully we're sorting all that out, and I think we are probably quite rapidly coming to the point where we will offer genetic testing to everybody. Now, once the gene has been identified in a family, you know what the other people in the family have got because everybody's going to have the same thing. But it's identifying in the first place which gene and what mutation, what change in the gene is, that can be quite helpful. And then the other big question, and again, Ros kind of touched on this a bit, is what about children? So children may be too young to have developed any cysts. So scanning them by ultrasound scanning starts to become effective, kind of mid to late teens, but earlier than that, you may scan a child and see perfectly normal kidneys and they've still inherited the gene. And the only way to know for certain one way or the other whether they've inherited the condition is with the genetic test. So should we be doing that? Should we be testing children? And there's this is not an easy subject, and there's lots of pros and cons towards doing that. There are big issues of autonomy. In general, in genetics, we don't like testing children unless there's a reason to do it because we're going to have a management issue. We'd rather let them grow old enough to make the decision for themselves so that they retain their own autonomy about when and where and how they want to find out. And I think the big question that's going to determine whether we do start testing routinely in childhood is there something that we can do that might impact on the future development of that disease? Because if there's something we should be doing in childhood that is going to slow down the progression, that then becomes a strong argument for testing in children. Don't think we're quite there yet, so there's lots of discussions between adult and paediatric nephrologists about what the right things to do. How do we do it? So in 2016, we were sequencing one gene at a time using a technique called Sanger sequencing. In 2022, we're doing whole genome sequencing. So I just want to tell you a little bit, without completely losing you, about what whole genome sequencing is. So the whole human genome is that circle on the right. And now this is where I lose it. So where is the button, Ross? On there. Okay, this tiny slice of the whole human genome is the 20,000 genes that make us. These are the protein coding genes. The rest of the human genome, most of which we haven't got a clue what it does, not a clue. And a lot of this, we call this junk DNA. Some of it may be, but it's not all junk DNA. There is going to be a whole load of stuff in there that turns genes on and off at the right time during our development, turns genes on in certain tissues and off in other tissues. We know nothing about it. What we know about is this tiny little slice here, 1% of the human genome. But the technique that we use with whole genome sequencing is we do sequence the whole lot, and that produces a huge amount of data that is kept in electronic form. We can do other techniques. We can do whole exome sequencing, which just won't go into huge amounts of details, but it's just a smaller proportion of that. And what we're mainly using whole genome sequencing for nowadays in genetics is to try and understand some of the syndromes and causes of congenital abnormalities and intellectual disability in children. And in those groups, we are starting to get diagnoses where we never were able to get them before. So in that group of genetics, part of genetics, we're really starting to get some really exciting diagnostic rates. But we're also doing that for PKD, and that has resulted in a lot of new knowledge coming really, really fast, which I'll take you through a little bit of it. Now, it is a bit of a misnomer, whole genome sequencing. We do sequence the whole genome, but we don't analyse it, because if we analysed all of it, first of all, we would understand what 99% of it was, and it'd probably take us about 5 years to come up with anything sensible. So what we do is, with that huge amount of data, we then just analyse the genes. We use a panel of genes that we know, all the genes that we currently know can cause cysts in kidneys to develop. So it's a partial analysis of the whole sequence. And the thing that we always have to bear in mind when we're doing kind of genetic testing of this complexity is just the huge amount of variation that there is between one person and another in our genome. So every single one of us carries, oops, I want to do that, the wrong thing. Every single one of us carries about 3 to 4 million variants in our genome. So the moment you start doing genetic testing of this complexity, you are going to find lots and lots and lots of variants. We know on average in the general population, PKD1 has we will identify about 13 variants that are different from what is published as this is the PKD1 gene. In a much smaller gene like PKD2, we might find one variant. Now, some of those variants we see time and time again, so we can immediately filter them out. We've seen that, we know that's fine, we can forget about that. But some of them will be very rare, which appear to have quite a subtle effect on the protein, may never have been seen before. And so often we are coming back to people doing genetic testing and going, well, we found something. We're going to call it a variant of unknown significance. We don't actually know what it means yet. So I think that there are still limitations with genetic testing. It's brilliant. It's giving us huge amounts of information. But sometimes it brings up a lot of questions that we can't answer as yet. The data, all that data from that whole genome sequence is stored with permission from each individual, which allows us in the future, when new genes are discovered, to go back and reanalyze it. And when we're taking people through whole genome sequencing, as some of you will have had WGS, we ask permission or consent for us to be able to store that data in something called the National Genomics Research Library, which is held by the NHS. And that means that we can start to collect genetic information about lots and lots of people with polycystic kidney disease. And researchers like Professor Ong can then go into that research library and interrogate it and start to ask the questions, what other genes are there? What can we learn from this? How can we take this forward? So going back to why we do genetic testing in the first place, and just give you some of the examples of where it can be helpful. So sometimes we get, this is a prenatal ultrasound scan. This baby has got cysts. They're quite large cysts. What we tend to see in the autosomal recessive PKD is small cysts, but these cysts look more like autosomal dominant. And this is a family where there is autosomal dominant polycystic kidney disease going down from dad and to his son, and then the new baby has got these cysts that are being picked up in utero. And what genetic testing is beginning to tell us is an answer to some of these questions. We just didn't understand why this was happening before. And now we've got quite a group of work that Albert has done, a group of young babies and children with significant early renal disease in PKD families. And we're beginning to understand that what is happening is that those children inherit what we call the pathogenic variant, the one that is causing clear PKD in the family. But they get a second variant from their other parent in the PKD1, which is so mild that it's not going to cause mum any problems. But if you put it together so that you've got one gene from dad with the pathogenic variant and one gene from mum with what we call the hypermorphic variant, the two in combination cause much earlier, much more severe renal cystic disease. So we're starting with genetic testing to provide some of these answers to these puzzles that we didn't really fully understand in the past. Talked about prognosis. So this is what we call in genetics genotype-phenotype correlation. So what does the genotype, the change in the gene, tell us about the phenotype, what's actually happening with the patient? And this is where the information has come from about the difference between PKD1 and PKD2. So if this is a graph looking at renal, we'll get there eventually, declining renal function with age, depending on the nature of the gene that you have and the change within the gene. So as we've been talking about, people with PKD2 have a much slower decline in renal function. Some of them will end up on end-stage renal disease, but a significant number won't. Now, these are different changes in the PKD1 gene. So T stands for truncating and NT stands for non-truncating. And what that means, in truncating mutations in the gene, the change in the gene is such that that protein is much, much shorter than it should be, may not even be there at all. So quite a severe effect on the protein. Non-truncating mutations are much more subtle. And what that might mean is you still get the PKD1 protein, but a bit of it is changed. Proteins are made up of things called amino acids, and a non-truncating mutation may result in one amino acid being changed to a different amino acid. So the protein is there, but it may not be working as well, functioning as well as it should do. And you can see the effect on progression to end-stage renal failure depending on the nature of the mutation. So if you have a truncating severe mutation, it's much faster decline of renal function than if you have a non-truncating PKD1 mutation. And so this kind of genetic evidence can start to give us some idea of what we might expect to happen to that individual in the future. Now, we do know that there's a huge amount of variation, even in the same family with the same gene fault. So this is not the only thing that determines prognosis. There are other things impacting on the kidneys that will make it more or less severe. But we know that this is a significant part of the risk. Another reason I said for genetic testing is to allow options for families to maybe not pass this on. I'm not going to spend a whole amount of time on this, but just to give you a flavour of what this is about. What we can now do, if we know the genetic mutation or variant in the family, for those families that want it, and I would say that most families don't, but for those that do, we can do something called pre-implantation genetic diagnosis, and that's using in vitro fertilisation techniques to create embryos outside the body in a petri dish. We can then take a single cell out of that developing embryo and do the genetic test on one cell. Now, I, as a geneticist, still find this mind-blowing because normally we're doing genetic testing on blood and we have thousands and thousands and thousands of cells to do our test on. Doing it on one is a whole order of magnitude. But what that then allows you to do with those fertilised embryos is to work out which ones carry the gene fault and which ones don't. It's going to be roughly 50-50. And then that enables you to put the unaffected embryos back into the womb so that you know that that embryo is not going to inherit PKD. So it's a possibility that we can do nowadays, so don't do it very often. And then the fourth reason for doing genetic testing is live-related donor transplantation. So as I said, what we're trying to make sure is that we do not transplant a kidney from a donor who has PKD but may be too young for the cysts to have developed into their relative, because that results in failure of the donor kidney, possibly with time, and a poorer prognosis for the donor themselves, because they're now down to one kidney, which isn't working particularly great. And so what we now do when we're thinking about a life-related kidney transplant for PKD is we make sure we know what the fault is, the pathogenic fault in the family is, and then we do what's called a predictive test for the donor. So we then test them for that specific fault that we've identified as causing the disease in the family to see whether they've inherited it or not. And that will tell us whether or not it's sensible to use a kidney from that donor. So what is new? What are we learning from doing genetic testing using whole genome sequencing? So some fascinating things come back, and I've got this very pretty picture from Albert. So I have to acknowledge that I pinched it. Because the work that people like Professor Ong did, that's telling us that these genes PKD1 and PKD2, they're not acting in isolation. They work within a whole network of proteins within the kidney that determine whether cysts are going to develop or not. And there are a lot of genes making these proteins. So it would make sense for polycystic kidney disease to be due, perhaps, as well as PKD1 and PKD2, it would make sense that they're possibly due to certain faults in some of these genes as well. And what's whole genome sequencing tell us is we now have this ability to look at lots of genes all at once. What that tells us is if you look at absolutely typical autosomal dominant polycystic kidney disease on scan, on ultrasound or MRI, and look at it and it's ADPKD, then we know that we will pick up on whole genome sequencing 80% of the actual underlying faults. So it's still 20% that we're not identifying the cause. And of those typical cases, yes, that's where your PKD1 and PKD2s are. They are the vast majority of those cases where we can make a genetic diagnosis. But when you start to move into the atypical group, and an atypical group may be small kidneys with cysts, very late onset or very early onset, then you see that our pickup rate is much lower. We're only identifying the underlying cause in 60%, even with this amazing genetic technology. But of that group, only around 56% are due to PKD1 and PKD2. And you start to find that in the atypical group, there's a much higher percentage of other genes involved. So what are those other genes? What are we learning about polycystic kidney disease? So we're learning that some of the classifications and what we thought we knew and what we thought was absolutely blindingly obvious is actually not so obvious. So we thought that autosomal dominant was due to PKD1 and PKD2, and then the autosomal recessive, where you have to have faults in both copies of this gene, called PKHD1, always caused lots and lots of cysts at birth and very, very, very early end-stage renal disease, and usually the children with autosomal recessive mutations in PKHD1 did not survive infancy. Well, we were wrong. And what we're now beginning to realise is that if you have milder variants in this gene, then the onset of the cysts can be much later. So we are picking up adults with cystic disease with 2 mutations in PKHD1. So we didn't realise that there was a much broader spectrum than we thought, and we were only seeing the very severe end of that spectrum. And now that we can test the genes, we're realising that it's much broader than we thought. The next group of genes that we're realising can cause polycystic kidney disease are syndromic causes. And we've known about tuberous sclerosis, particularly due to faults in TSC2 for a long time. And you wouldn't expect in children and adults with tuberous sclerosis to just see polycystic kidney disease, but we know that that is a cause because they're going to have lots of other problems as well. But this is a fascinating one, and we're making more and more diagnoses of this condition, which is due to a gene called HNF1 beta. And HNF1 beta variants cause a condition which we call renal cysts and diabetes syndrome. And individuals with this, it is very, very variable, even in the same family from one generation to another. You will get some individuals, all they have is renal cysts. We see others that get diabetes, and diabetes is very common in this condition, sometimes in younger people, sometimes in older people, the diabetes develops. But you see other things as well. Sometimes we pick it up on the blood test. They have very low magnesium levels, or they may have high levels of a liver enzyme called gamma GT. Some of the women have congenital abnormalities of the uterus. They might have a bifid uterus. We also see some occasionally some changes in the pancreas as well when we scan them. So it is a syndrome consisting of a number of different things. In the children, sometimes we see a single kidney or maybe no kidneys at all. But it's so variable that some of our patients with polycystic kidney disease are turning out to be due to faults in HNF1 beta. And we're getting quite a lot of those at the moment. Also, what we're beginning to understand is the role of the polycystic liver disease genes. So in the past, we had this simple view that some genes cause polycystic liver disease and other genes cause polycystic kidney disease. Well, we should have known that wasn't quite right, because we know in PKD 1 and 2, there's an increased risk for liver cysts as well. And now we're realising the other way around, that all these genes, which are classically cause polycystic liver disease, can also be associated with kidney disease. So actually what you've got is a spectrum. On one side, you've got a lot of liver cysts. On the other, you've got a lot of renal cysts. And then there's everything in between. And these genes sit in that in-between position. So we are identifying faults in these genes as well in the families that we test. And then, too, that some of you may know that you have this. This is DNA JB11, and this is a scan where this is the kind of typical scan we might see in somebody with PKD1, these very large kidneys, and this is what we see in families with a fault in DNA JB11, these small, normal-sized kidneys. So small, normal-sized kidneys may not always see the cysts, may require MRI to see them. And this condition is a much older age of onset and a much slower progression to end-stage renal disease. So although some people do end up requiring dialysis, that is not the majority. And then this is the latest one, and this is the last gene I'm going to tell you about. This is IFT140, and this was really picked up from these big gene libraries that we're kind of collating together from whole genome sequencing. So we now realise that this can cause a fairly mild version of polycystic kidney disease with limited progression. Some people do end up, but most people don't, on end-stage renal failure. These produce very large cysts in the kidneys. So the people have very large cysts with a few cysts in the liver, presents much later. And we realised that because many people with some large renal cysts presenting at older age who do not go into renal failure may never ever be identified, we are beginning to understand that this is very, very underdiagnosed. And so looking at samples that have been collected in biobanks, so general population samples, looking at whole genome sequencing, we're now realising that this is probably the third commonest PKD gene after PKD 1 and 2, but we're not going to diagnose most of it because there's no reason that an individual might have a scan of their liver. And I think that is my last slide. So hopefully, timing that brings to us end.
Thank you. Thank you, Jackie, for taking us through a very complex and changing subject very, very quickly. So I'm sure there are lots of questions. We probably don't have time to address them all at the moment. There will be time in the later Q&A session in the afternoon. But any burning questions? Ah, okay. Sorry.
If a gene is identified in a child, will it always go on to get the full-blown cysts, or is that variable?
No, it will. It will. So, so the gene is present from birth. So the age at which you identify it doesn't really change anything. But if you've tested that child because they've got cysts, then we would expect that to be quite severe disease as they get older.
Great. Oh, David.
My brother and myself have got this problem. We both have two daughters who have been checked at 40 and they haven't got a problem, thankfully. What about grandchildren? Do they need checking at some point in time?
The gene doesn't skip generations. And so if they haven't got it, they cannot pass it on. So I suppose it depends on the confidence that their doctors have that they haven't got it. But if they haven't got it, no, the children do not need to be checked.
Right. I think so. We'll take a question online because otherwise they'll think we're ignoring them. So Tess is going to.
Yeah, there's a couple of questions really about age of testing children, which is often asked. Also, particularly if one of the questions there's been a negative, presumably scan earlier. So again, to do with age of testing and when.
So I think that you'll get a different answer to that depending on who you ask. As a clinical geneticist, I have been trained to not test children unless there's a very good reason. So I suppose if you were to ask me, I would say I think if they're normal scan and their blood pressure is fine, I would wait until they were old enough to make the decision for themselves. I think if their scan isn't fine and their blood pressure is not fine, then yes, I would test. And then, in between, it ultimately has to be a personal decision. But I think it's a difficult decision to make for your child. And we have picked up the pieces of so many, when the child has turned on their parents and said, I wouldn't have done that. I didn't tell you to do that, didn't ask you to do that. And I think, for something that is affecting you for the rest of your life, you've got to, if at all possible, be given an opportunity to make that decision for yourself. Now, the age, obviously, some 12-year-olds are probably capable of making that decision and some 20-year-olds are not. That's very individual. But I think you have to be given an opportunity to make it for yourself.